Yeah, Dr. Bill Schaefer. I'm an interventional radiologist, also board certified in diagnostic radiology and internal medicine. Interventional radiology is a specialty that is really an image guided procedural based specialty. And we do a lot of things in almost every part of the body using image guidance. So we'll use ultrasound, we'll use CAT scan, some people will use MRI, use a lot of fluoroscopy. So we do things through tiny little incisions, sometimes through vessels, sometimes not through vessels, and we look at what we're doing using all those imaging modalities. And it's you have to understand radiology first in order to know what you're doing with the imaging and where you are. So that's why you're a radiologist first, then you kind of go into the interventional side of it. So we take care of patients all day long. Right. You're looking elsewhere while you're working on a patient who's in front of you. Yep.
Yeah.
Yeah. For interventional radiologists, we work inside all different kinds of blood vessels in patients, arteries, veins. We work anywhere from the brain to the foot. And so it's really a broad specialty.
Yeah.
We also work in some of the lymphatic channels at times too. So we are really all over the body.
I don't think I knew that.
Yeah. And yeah,
That's
we do that
crazy.
too. It's really, as it relates to varicose veins, these are superficial veins of the legs is what we deal with here. This is really just an extension or a natural progression of what IR docs do.
Yeah.
This is actually this is more limited because we're just dealing with legs and we're dealing
Yeah.
with superficial veins. This is yeah, some of the things we do are way more complicated.
Yeah.
And definitely, especially if you're in the brain, have a lot more consequences than working in a superficial vein in the leg. So but I will tell you that working in leg veins is very satisfying because there is often immediate relief of symptoms and patients feel better quickly. There was a patient I treated a couple years ago that literally came in a wheelchair with giant wraps on their legs and continuous weeping of the legs. And not all those patients have, believe it or not, have sometimes that's just lymphatic, but
Yeah.
this patient actually had a venous component to that. We fixed his veins with several procedures, and by the time I did his post-op, he was walking and no longer in wraps.
And that's
It's incredible.
within a 3 month period.
Oh,
maybe?
absolutely. Oh, yeah. It was definitely within 3 months.
How-
Yeah.
that's
It's not
extensive.
instant, right? But yeah, within a couple months, he was out of his wheelchair and walking and no longer required continuous wrapping. And yeah, and it's great. And I saw a patient today who wanted to go on a trip and was having problems with one of her legs swelling, and
Yeah.
we treated the vein that was malfunctioning in that leg, and she went on her trip. She's back today, no swelling, and it's just there. People are so grateful and thankful because it hurts. I mean,
Yeah.
it's painful.
Before
Yeah, it's
I got it done.
yeah, it's amazing.
Yeah.
And we've come a long way understanding that this is actually this is a really this is a real medical disease. And and it ends up being a chronic disease, just like most things. So people will sometimes get different varicose veins that recur,
Mhm.
and then we need to treat again. In the olden days, and it still happens today, the procedure to rid people of varicose veins and the underlying saphenous insufficiency was a vein stripping, which was a 6-week recovery, large scars, general anesthesia, very, very painful.
General.
Yeah. Uh, they probably would do regional blocks if they did it today, but back when
Okay.
they did this, it was general. Phlebectomy, which is probably the closest cousin to vein stripping, is literally taking out short sections of a vein so that the sections in between don't get blood supply and your body can just reabsorb those sections. But vein stripping was literally removing the entire vein. It didn't guarantee you didn't get varicose veins back either, but it
Well, I
was
mean,
6 inch, like, yeah, they go from groin to ankle incisions, and then they literally just strip the vein out. So it's beautiful that we can now just go into the vein with a catheter and close it with glue or with heat.
What's maybe the average size of a catheter that you're using?
Oh, it'd be about the size of a spaghetti noodle.
Yeah,
Yeah.
that's what I remember mine.
Yeah. That's, yeah.
Just small incision by the
Yep.
ankle.
And that's it. Yeah.
Okay.
And for glue, we can go all the way down to the ankle. For the
cool.
for the heat catheters, it's generally up closer to the knee. So there's heat treatment or thermal based treatment, which is either laser to create the heat or radio frequency waves to create the heat. And it's just there are two different ways that we create heat in cautery. There's a glue procedure, which is cyanoacrylate, the same component of crazy glue.
No kidding.
It's crazy glue, yeah, but it's specially formulated crazy glue. And we've used glue in other parts of the body for years, not just veins of the legs, but and then there's foam-based sclerotherapy, which is medication which inflames the vein, and the vein literally sticks itself closed. And then the body will reabsorb that over time. And then finally, there's phlebectomy, where we actually remove segments of the vein. But the important thing is to not just treat the visual varicose veins, because they're just a symptom and a surface manifestation. Something is feeding them. So if you don't treat the feeding vein, which is unfortunately what happens if you don't really understand venous disease, if you just take out somebody's varicose vein, it will come back relatively quickly because you haven't treated the underlying problem. Lasers, and I've never used a laser, full disclosure, but it's a little got a little more power than RF. There's technical parts that are different, so you stay back further from where the superficial system joins the deep system. In my experience, and this isn't really scientific, I see more recurrence up high with lasers, probably because we didn't treat as high. And so you get recurrent varicose veins coming off the trunk up high, and then they seem to recur. I have not seen that with RF. I just not as often. So
yeah, RF is what we use.
Yeah. You use a combination of RF and maybe sclerotherapy and maybe some phlebectomy. But yeah, and then you just, have, again, that's the importance of the mapping. You have to figure out which of the veins are really the culprits in the truncal supply.
What does the process look like? Like, let's say you call today, you say, hey, I think I got a problem.
Yeah.
What's the process from start to finish?
Usually patients will come in for a consultation. Takes about 45 minutes where we're talking to you, seeing what your symptoms are, seeing what your concerns are. And then I will do an ultrasound of the legs to look at your venous system in the legs and determine if your symptoms fit with what's happening with the ultrasound. Because there's some people with varicose veins that don't require treatment because they really have no symptoms whatsoever. And then there's some people with leg symptoms that aren't from venous disease at all. And so I try to help those people figure out why are my legs hurting? Is it neuropathy? Is it from my lower back? Is it from my pelvis? Is it from a hip? And that's where my background in internal medicine really helps, because I did a lot of listening to patients doing that before I did radiology and interventional radiology. Sure. Yeah, I started off in the Air Force as an internal medicine doc trained in the Air Force after medical school, and went to a smaller base where did a lot of outpatient medicine, a little bit of inpatient medicine, then went on and actually became a hospitalist where I just did inpatient medicine. That was for about another 8 years. At that time, I also got into hospital administration, so I was the medical director of the hospital for that little bit. Then decided that I really liked the procedural aspect of medicine and went back and did a second residency and then a fellowship in radiology and then interventional radiology, and also was doing medical administration at that point, managing our IR division, and then being a vice chair for the Department of Radiology at the university. So, and one of the reasons, frankly, that I enjoyed doing venous disease is because I don't have to wear lead to do it anymore. So
that's right.
After 20 years of wearing lead, it's a relief not to wear lead.
Bibs
bibs and skirts. Yep, all day long. Yep. it gets heavy. Yeah, I never got bulky.
Yeah.
most so there's really there's two major categories. Most people have a genetic component to this. It's a family history, and there's a genetic predisposition to developing faulty valves, which then break and allow blood to flow backwards in the leg veins. That would be the majority. But I also see patients who have post-traumatic varicose veins develop usually after a major injury.
Yeah.
It's not just a bump on the knee. It's I've dislocated my knee. I've broken my ankle. I've had major fractures in the leg. And sometimes those will crop up.
Do you think that's due to like the inflammation that occurs in the area?
I think it's
No?
just from disrupting the little perforator veins in general that
Really?
connect the superficial and deep system. And when you stretch and pull and break veins,
Okay.
when they grow back, they're damaged.
Oh.
I think it's just disrupting the way they normally function. Yeah, it's generally you may have been able, and again, things that exacerbate it are anything that makes your veins struggle to
Mm.
drain out of your legs. So if you have an increased BMI, and I mean significant increased BMI,
Yeah.
that just puts a lot of weight on the
Okay.
exit points from your legs, and so that can maybe accelerate how fast you might get varicose veins. If you have certain pulmonary conditions, COPD or obstructive sleep apnea, that's really significant. You actually have an increased right heart pressure, which puts pressure back down the legs. But those aren't, not everybody who has those things will get varicose veins.
Yeah.
So you have to have the predisposition. And some people can stand all day, never have a problem in their life.
Isn't that crazy?
Yeah.
It's like those people that smoke 2 packs.
Yeah. Never have a
have
problem,
cancer.
never have any problem, never have lung
Dude.
problem. Yeah. It's just if you have the predisposition and you have the other factors, it may accelerate, how it happens. But we see healthy 24-year-olds with significant varicose veins.
Yeah. Well,
It's
mine started to show
yeah.
at 18.
Yeah,
And
absolutely.
I was underweight.
I hear that all day
Crazy.
long. I hear it all day long. It is.
Yeah.
Yeah. And wearing compression can again help slow down how fast that gets.
Yeah.
They worsen, but they do tend to worsen over time. Yeah, you can't really once the valves break, they break.
Yeah.
And they're so thin and papery, we really don't have a way to do replacement valves. It's not like a heart valve. That's an actual, these are tiny little papery things. I'll tell you the giraffe story. Giraffes don't get varicose veins. They don't have valvular issues in their veins, but they have much higher pressures in the veins in their legs because they're huge, right? They're giant creatures with tiny legs, but they don't get varicose veins. Yeah, they don't because they have proper valvular function and probably have a much higher, better wrap around their veins as well. So yeah.